Kia ora everyone, welcome to this Goodfellow Unit Webinar on eating disorders. So tonight we are talking with Dr. Marion Roberts, who's a clinical psychologist and a senior lecturer at the University of Auckland, and her research and teaching is based primarily on eating disorders. So she's our expert specialist tonight. Welcome, Marion.
Thank you, really lovely to be here, and I'm thrilled to have the opportunity to be able to speak to such a wide range of primary care practitioners. This is an issue obviously very close to my heart, so it's really fantastic to have this opportunity. So thanks to Goodfellow for having me along. So let's jump straight into it. There are still a lot of misconceptions that float around about what an eating disorder is and reasons behind it. One of the things that still is very prevalent is this idea that eating disorders aren't serious, that they're lifestyle choices or that they're about vanity. Look, it simply isn't true. Eating disorders have the highest mortality rate of any psychiatric illness, anorexia nervosa in particular. This is either due to death because of suicide or due to medical complications. So there certainly are an absolutely serious thing for us to be considering. The second misconception is that dieting is a normal part of life. I mean, again, I would disagree here, and particularly when we're talking about an eating disorder, this is not just dieting, this is a huge level up from there. This is life overwhelming. This is interfering with every single aspect of this person's ability to go about their day-to-day life. This third one, and this is often spoken in that adolescent age group, is that eating disorders are a cry for attention, or that there's somebody that's simply going through a phase. Look, if we intervened with evidence-based care at this point when we thought it was maybe just a phase, I wonder how much better those particular clients would be rather than progressing down a trajectory of a really protracted length of illness. So this is just not the case as well. This is not the case. Families, particularly parents, are to blame for an eating disorder. This one really is sticking around, and it's just not true. Biology plays a huge role in eating disorders, and we know that families can in fact be one of the biggest allies in recovery. And when they are empowered and equipped and part of that treatment process, that can just be fantastic in terms of treatment outcomes. And finally, this notion that eating disorders only affect white middle-class females, and particularly adolescent girls. Eating disorders do not discriminate by gender, they don't discriminate by class, they don't discriminate by geography, they don't discriminate by sexual orientation. You know, these are illnesses that affect people across various different spectrums. So what do we know when we're looking at local statistics? When we look at how this presents in New Zealand, we know that up to 50% of high school girls report feeling fat or report wanting to lose weight. We know that 5 to 10%, and again, this is Australian statistics, this one here, of adolescent girls use dieting plus some form of purging laxatives or diet pills. That's a large proportion of our young girls, where this is really having a significant impact on their life. And this is research done back in 2003, truth be told, for my honours thesis, that found that nearly a third of female first-year undergrad students scored above the clinical cutoff on a disordered eating measure. A third, nearly a third. It's a really high proportion.
It's huge.
It's huge.
Yeah.
It's huge. Yeah, it really is. So this is something we really do. We need to take this really seriously. And it's no surprise that it's that high when we look at the images that are getting fed to our young people in particular these days. Yeah, nothing tastes as good as skinny feels. Yeah, food is for fat girls. These images were amongst the first few things that popped up when I Googled Thinspiration, hashtag Thinspiration. And these messages are just prolific. Let's be really aware though that what starts an eating disorder off, where this thing might play a role, is not the same as what keeps an eating disorder going. So we can't just blame this on Thinspiration, we can't just blame this on social media. Anorexia nervosa has been around for a very long time, hundreds of years. So this isn't just a social media thing. However, in our culture, social media certainly doesn't help. So the role of the primary care clinician. So GPs and practice nurses, there are frontline clinicians, as you'll all know, when in the context of any mental health presentation, really. So primary care physicians are uniquely placed to do screening, to do early intervention, and to do referral, and to do it well for these cases. Early intervention, we know for an eating disorder, is absolutely critical. The earlier we intervene with evidence-based treatment, the better the outcome for these young men and women. So again, from a different perspective, same point, so eating disorders impact can be minimised or even avoided by prompt early intervention and appropriate management in primary care or referral when that is appropriate. Watchful waiting, I really feel, is just not a good idea with this client group. So in the interest of assisting you with that process of screening and assessment, what I want to shift into now is looking at diagnostic criteria across the spectrum of eating disorders, just to be sure that everybody's familiar and up to date with what that looks like. So we're going to look across the full spectrum of eating disorders, starting at more the restriction level, so the restriction end of the spectrum down here, more the anorexia nervosa end. We're also going to talk about more that lack of control and excessive appetite end, which is more our bulimia and binge eating disorder presentations. And I'm also going to talk a bit about ARFID, which stands for Avoidant and Restrictive Food Intake Disorder. This is a new classification for an eating disorder in DSM-5, and it's well worth spending some time on. So starting with anorexia nervosa. So we have 3 criteria in DSM-5, a restriction of energy intake, resulting in significantly low body weight, or a less than expected based on age, sex, or developmental trajectory. That's criteria 1. So there's restriction of food, which means we've got a loss of weight, or we're not staying on that trajectory that would be expected. Secondly, we have an intense fear of gaining weight. So these are our cognitive psychological symptoms, or we've got persistent behaviour that interferes with weight gain despite a low weight. Okay. Thirdly, we have a disturbance in body image, so how they experience their body, their ability to accurately judge their shape and size is impaired, or we have in this criteria a lack of recognition of the seriousness of the low body weight. And that's seen really, really frequently. We have 2 subtypes, restricting type, which is where the behaviour or symptomatology is around restriction of food, so skipping meals, having really small portion sizes, going whole days without eating anything at all. And then we have those that are doing both the restricting but also falling into either binge eating and purging patterns or the purging by itself. So they may be restricting, but then they have whatever X amount, a little bit more than maybe they were planning to have, and then they will purge that afterwards. Highlighting some changes in DSM-5 compared to DSM-4. So criteria A, the BMI requirement has been removed. There used to be a BMI metric on criterion A, but that proved a little unhelpful in that people were sticking to it quite strictly, where people actually met that criteria with the intention that was behind it. We also, criteria B, you'll see that we have that or word in there. So it used to just be intense fear of gaining weight, but now we have the or, this behaviour that interferes. Because some clients, they do present without the fear of gaining weight, and they can articulate very clearly that, you know, they're not afraid of it, yet they won't engage in the eating that's required in order to recover weight to a healthy level. And criteria D, which was in DSM-4, has now been deleted. So that was the amenorrhea criteria required for 3 months or longer. This is deleted because, as you all know, there's a huge range at which amenorrhea comes into the picture. This is obviously highly inappropriate for males with anorexia nervosa, so that was getting a little bit in the way of diagnoses. And also there was no impact when there was no relationship when research looked at the impact or the severity on day-to-day life, whether amenorrhea was present or not. Right. So the rationale was to take that out there. In terms of severity indicators, we have, this is where our BMI metric comes back in, but again, it's really as an indicator here. And you can see that extreme and life-threatening is considered under that 15 BMI. So what does this look like in the clinic? I've got a little case study here to go through, and I did just want to mention as a bit of a disclaimer, these aren't real cases, these aren't real clients, these are fictional, based on clinical experience, but very much realistic cases in terms of what we see. I'm also going to talk a little bit about these clients' experience when they go and see a GP. Again, that's fictional, but it's based on an amalgam of what I kind of hear in my clinical practice and what's reported through support agencies and so forth.
Yeah.
So let's start with Claire. So Claire couldn't believe what she saw in the mirror. She was so fat. It must have been the extra tomato and the bit of cheese she had at lunch. She usually didn't eat cheese, but her dad was watching her. The cheese was right in front of her and he kept pushing her to have some. Now all she could think of was getting rid of it before her body absorbed the calories, really overtaken cognitively. Claire knew that her dad would be watching the bathroom for a while after the meal, so she made herself sick in one of the small bags she kept hidden in her room. She would flush it later. Claire was grateful that the family still had the exercise machine in the lounge, and she headed downstairs to work out. Claire has a BMI of 15.4. So she would quite clearly meet diagnosis for anorexia nervosa purging type. And we can see with that BMI of 15.4, she's really on the cusp of that life-threatening metric there. So taking this case study a step further, so a few months earlier, Claire's parents had taken her to the GP due to their concerns about her behaviour. Claire is 17. She didn't want to talk with her parents in the consult. So after sharing their concerns very briefly, the GP asked her parents to wait outside. Claire reassured the GP that fitness was really important to her. She was very active at school with sports teams and with her running, and she was naturally quite slim. She said that her parents were being paranoid, that she just ate most of her food at school because she was so hungry after all that exercise, and she was less hungry at dinner time when the family ate together. She denied any vomiting. The GP took her report at face value, given that it was really quite convincing. Also, they noted no major concerns in the observations that the nurse had taken. The GP calls the parents back in, lets them know there's nothing to worry about. Perhaps she's just going through a bit of a phase, but this is normal for a teenage girl and she'll likely grow out of it. So I by no means mean to be pointing any fingers at GPs with this, but this is the kind of story that quite often is heard of when we're talking about clients and their histories and their engagement, attempt to engage in treatment. So a couple of take-home points from a case study like this. And this is absolutely true. Anorexia nervosa can be an excellent liar, I've worked with these clients for 15 years, and you don't get a really good radar for when this is, when you're getting sold a story or when you're not. You know, there's no litmus test for it. It can be very convincing, and paired with that lack of insight, it can be really, really hard to know what is the full story and are you getting the full story in the room. A lot of these young people as well, and particularly with anorexia nervosa, they're very, they're lovely young women. They're very compliant, they do really well at school, and so they turn up in your office and they want to be a really good patient. So there's a level of that as well. So it's just something to be aware of that may be playing a role. Take-home message number 2, thinking about Claire, particularly for adolescents, including informants other than the patient in assessment is really important. Okay, so parents, if they're concerned about these kind of things, it's important to give them the airtime to be able to talk to that. Ask them for examples. Say, what happens when you do sit down? What happens when you do encourage her to eat something, and really try and gather some rich data that way as well. And the third point here is that basic medical observations can appear really stable even in someone that is severely malnourished. And I may be preaching to the choir with this, I'm sure, but it's something to be really mindful of, that sometimes it's a really good idea just to do those investigations really well.
Marion, just on this, for adolescents, do you find that you feel the need to ask their permission to involve their parents in the consult? Yeah. How do you manage that, that difficult, keeping their trust, allowing their parents to have their say at the same time?
Yeah, absolutely. It's a really good point, and I think that confidentiality and that trust and rapport is important to navigate well. I'm really careful that I set it up very clearly from the beginning. Yes. Mostly assessment sessions are done with a young person and usually mum in the room at the same time. Oftentimes they're happy with that. Sometimes they're not. So in the cases when they're not, then we just talk about the limits of confidentiality, but do explain to mum, so that we can do this assessment well, it is important to have that time. And parents, by and large, really understand that, and they're happy to leave that kind of trust, I guess, in the clinician.
Right. So getting that little bit of both. So you're getting the time with the parents and the client as well as the separate time. So keeps that trust, doesn't it?
Yeah, definitely.
Thank you.
Okay. So moving on to bulimia nervosa. So when we think about DSM-5 criteria for bulimia, we have recurrent episodes of binge eating. So binge eating is defined by eating an excessive amount of food in a really short or discrete period of time, paired with a sense of lack of control. So somebody might eat a really large amount of food, feel really full and really overfull, but if they didn't have that sense of a lack of control about it, and if they didn't have these other behaviours going on, we wouldn't consider that a binge. So second criteria B, for bulimia, we have recurrent inappropriate compensatory behaviours, or ICBs, to prevent weight gain. So oftentimes this is vomiting, that's by far the most common one, and less commonly things like laxatives, diuretics, and we also have things like fasting and excessive exercise as compensatory behaviours, so things that they're doing to make up for the food that they have eaten. Frequency criteria here is at least once a week for 3 months. That's a change from DSM-4 when it was twice a week for 3 months. That criteria has been dropped to allow more people to come out of subsidiary diagnostic categories and into the actual category that's a better fit for them. And then we have criteria D, the sense of self-evaluation being unduly influenced by body shape and weight. Again, getting into the cognitive psychological features with this criteria. Criteria E is an absence of anorexia nervosa, so an anorexia nervosa diagnosis would always trump a bulimia nervosa diagnosis, and we have similar subtypes in terms of a purging type or a non-purging type. I already mentioned the frequency change in criterion C, so that's once a week for 3 months would meet criteria for binging and purging for bulimia nervosa. And then thinking about those same severity indicators again, so mild would be 1 to 3 binging purging episodes per week, and then through to extreme being 14 plus or 2 or more times a day. And it can be much higher than that as well in people with a really severe illness. So let's have a look at another case study. So this is Amy. She struggles with her body weight and shape and tries to be strict with herself about what she eats. She skips breakfast but has lunch and dinner so that she won't arouse any suspicions. Amy makes sure she has smaller portions than the rest of the family and will not let herself snack between meals. However, Amy really loves chocolate, and a couple of times a week the cravings get too much for her. She goes to the supermarket on her way home from school, buys a couple of king-size bars of chocolate, a tub of chocolate ice cream, and some packs of chocolate biscuits. She races up to her room and she eats them all. Amy feels really guilty, really sick afterwards, likely a lot of shame happening with this behaviour as well, and she worries that she'll become fat after eating all of that food. She's never been able to make herself sick, so she refocuses on her strict eating plan and goes for a long run later that night. Amy has a BMI of 23.8. So if you think about Amy sitting in your office, there's nothing about her when you look at her that's going to say this might be an eating disorder case. Yeah. She presents well within that healthy BMI range, and it's a nice reminder that an eating disorder could be anywhere.
That's right.
It's not just a severely underweight young woman. It could be anybody that you're walking by on the street. So her diagnosis will be bulimia non-purging. So a couple times a week she said to the supermarket, so very much meeting that frequency criteria. Now, following this story on, Amy has also been to the GP recently at the insistence of her parents. She's also 17, like our previous case, and Mum came along too. Mum tells the GP she thinks that Amy has depression and that she's making some good decisions, like doing lots of exercise to try and boost her mood, but that it's not working, and Mum worries that antidepressants might be in order. Mum's happy to leave the room to give Amy some privacy with the family GP, whom Amy has really good rapport with. Amy breaks down with her GP, discloses the restrict and binge cycle she's in and how unhappy it is making her, and asks for help to tell Mum. The GP does physical obs, orders bloods including electrolytes, and brings Mum back in. They make a plan together for a specialist referral to see a clinical psychologist. Mum and Amy are given some information about bulimia nervosa and a pamphlet for the support organisation Edens. Okay. Really lovely ideal case scenario with that kind of a one. Really great opportunity there. The GP's given psycho-ed, they've given support for the mum, they've made those medical observations, and they've made a referral because they've had that rapport and that trust as well with that young person.
That's right. Yeah. You've briefly mentioned the medical observations, and one of the questions that has come in are there any biochemical markers that can be checked for a blood test if a practitioner suspects there is an eating disorder. For example, liver function. I think you're going to come on to them a little bit later, but yes, there are out there. There are things that we should be looking for.
Yeah, absolutely. And sometimes with cases where we were working with them already, maybe they're known to us as an eating disorder client and they're denying purging. Sometimes, we can do these little chemistry markers as well and have a little look, and that'll tell us, how's the potassium looking and that kind of thing to help inform. And definitely we'll come on to that.
Sorry, there was one other question, which is, do you have any tips on what GP and practice nurses can say or do that quantifies an effective brief intervention in the early stages?
Yeah, it's a good question. And again, I wonder, can you remind me of that one after we've done the assessment stuff? Yeah, because we're going to move into looking at assessment and how to do that really well, and that will naturally kind of lead into answering that question. Yeah, but really good thing to be flagging. So we've done anorexia nervosa, we've done bulimia nervosa, and now we're looking at binge eating disorder. So this used to be classified under the not otherwise specified category in DSM, but in DSM-5, it's come out of that kind of catch-all category and it has its own diagnostic criteria, which is really appropriate. So binge eating disorder, essentially this is bulimia without any purging behaviours. So we have recurrent episodes of binge eating. We've got symptoms such as eating rapidly, feeling uncomfortably full, not feeling hungry but still eating a lot, eating alone due to embarrassment or feelings of guilt and self-disgust. There's a lot of psychological features here. There's a lot of shame and guilt and self-loathing as well in this binging behaviour, as evidenced by criteria C. So marked distress regarding this, at least once a week for 3 months in terms of frequencies, and as I mentioned, an absence of any kind of compensatory behaviours. So typically people with binge eating disorder are in larger bodies, so they're more at the higher end of the weight spectrum. So having a little look at a binge eating disorder case study. So Susan is a 38-year-old mum of 3. She found it hard to lose the baby weight after each pregnancy, which ended up having a compounding effect for her. Susan feels quite disgusted about her appearance and she avoids intimacy with husband Steve and is leaving the house less and less. All of this is resulting in low mood. She's tried various different diets, Atkins, carb cycling, Jenny Craig, vegan, and a smoothie thing that she can't remember the name of. Despite desperately trying to be good with these diets, it's a really good little flag if someone's trying to be really good, or stick really rigidly to something. Susan would invariably turn to food for comfort, which then spirals out of control and into a binge. Constant failure in dieting attempts results in lower self-worth for her and a sense of having no willpower to make her own choices, which then generalizes to feeling hopeless about life in general. She feels a failure as a mum, given that her fatigue means she can't keep up or play with the kids. Susan has a BMI of 32.8. So this is quite a typical binge eating disorder presentation. And as you can see, that it's quite easy for this to fall through the cracks.
Yeah, I can see that. And it also be diagnosed as something separate as depression or anxiety.
And it may be the case that she does meet criteria, and it is both. But it makes us kind of think a little bit more carefully about, well, what's underlying what?
Yes.
And if we're just treating the depression, how effective is that actually going to be when actually what's driving it is something else?
That's right.
Yeah. So Susan visits her GP for low mood. So that's what she's decided to present with. GP prescribes an antidepressant paired with diet and exercise advice, given her BMI. So something like this, I feel like it's a little bit of a missed opportunity to explore a little bit more with her. It's something that I would be thinking in somebody presenting like this, who's obviously not going to turn up and tell you all of these details about their eating patterns, is just to carefully ask some open-ended, curious type questions. So you can ask, what's your diet looking like at the moment? What kind of things are you eating? What's the pattern of eating? Some good questions are things like, can you tell me what went on yesterday? Just to really get a sense of, is there anything bingy happening? And those non-verbal cues, and I'll come to this, but those non-verbal cues when you ask these open-ended questions can be really, really informative. You probably see, as I've mentioned a few times, a lot of shame and guilt with this kind of behaviour. So you're going to see those downcast eyes. You're going to have, eye contact's not going to be met. You're going to see it in their demeanour, and that's a good little indicator to say, hey, maybe I need to just try and open this up a little bit more if I can with this person. The other thing that I thought it would be helpful to flag in this case is just to consider, diet and exercise advice entirely appropriate and at the surface level, isn't it? But I guess it's just being really aware and thinking, what's the impact for somebody like Susan, who already has this sense of constant failure in sticking to a diet, to then give her advice about her diet. You know, she's probably not going to, it's probably not going to be overly helpful for her sense of self and for her feelings of hope about the future. So
it's more that thinking around the diet, or the way she approaches food, as opposed to the actual quantity and type of food, which is more sort of tangible, I think, and easier to advise on. That thinking and thought process and psychological impact that maybe needs to be addressed.
Absolutely. And look, it's a really hard thing to tease out. It's very much something that you do kind of almost need that specialist eye on it, and those right questions to ask, and where is it pushing too much, and where does it feel appropriate. So it's not an easy thing to tease out, especially in somebody who's feeling very shut down about that kind of thing.
And for someone like this, you know, the idea of bringing them back to your clinic for follow-up, and then maybe having that on your radar is actually maybe there's something else underlying it, and delving into it further down the track, because it's very hard to necessarily think of everything when you first start seeing someone.
And especially in the context of a 15-minute consult.
That's and you've got all this information and processing it, but asking them to come back and follow up on it, and see how she's going, and then
see if she'll open up a little bit more,
probe it,
assuming that there is something to open up about. Finding that balance, absolutely. Okay, so I mentioned avoidant restrictive food intake disorder, or ARFID. So this is something that typically presents in younger children. This is an eating or feeding disturbance with a persistent failure to meet nutritional needs. And as a consequence of that, we either have significant weight loss or a growth failure, a significant nutritional deficiency, a dependence perhaps on supplemental feeding, Fortisip or something like that, and or marked interference with psychosocial functioning. So these are kids that are only eating Vegemite sandwiches, nothing else. Maybe a banana and Vegemite sandwiches, or maybe this is a kid that's only eating foods that are green. Or maybe it's a kid that only eats smooth things. And the repertoire of food intake is incredibly restrictive. Okay, and this is not explained by a lack of availability of food or by cultural sanctioned practices. This is not an anorexia nervosa or a bulimia nervosa or a body image disturbance. We have no body concerns with ARFID. It's not a focus on a distortion of body shape or weight, or a sense of low body esteem. That's not really part of the picture here. Okay, and no medical illness as well to explain. So sometimes people call this extreme fussy eating. Sometimes people call this food neophobia, because that ability to try something new is just not even an option with some of these kids. So I am saying kids because typically it is those younger ones, but it can present older or have a protracted presentation. I should say this is very new, so all of what we know, our knowledge base on ARFID is very limited at this stage, and particularly when it comes to treatment intervention. We're really just being guided by what we know from other eating disorders. But we have these three hypothesized subtypes of ARFID. The first is the avoidance subtype, so food is avoided based on negative or fear-based experiences. So maybe they did choke on an apple at some point, so then they cut apples out, and then it started to generalize, they cut out fruit, and then it started to generalize, they cut out anything fresh, and they'd only have processed things, or they'd only have dairy, something like that. Maybe in response to nausea or vomiting in association with food. Sometimes as well, this can be so maybe mum has a peanut allergy, so mum's really sensitive about no nuts. So the kid then takes that on. The kid doesn't do nuts because we don't want to have that same thing happen. And then all of a sudden, what if it's not just nuts? What if it's dairy as well? So cognitively for them, it spirals.
It's a process,
absolutely. So that is the first subtype. The second one is the aversive, so only accepts limited foods, as I was mentioning, only the green foods or only the smooth foods. And the third is the restrictive kids. These kids have a really low appetite drive. So they just don't get those same hunger cues. that typically that experience. They've got a little interest in eating. That's just not their gig. They're not really into it. So they're quite hard to work with because they have quite a limited motivation to make any changes because they just don't really, this doesn't really bother them. Yeah. Now ARFID really self-resolves. Okay. Obviously there's a spectrum of fussy eating in kids that they go through, but this is something that really sticks around. It really hangs around, and if anything, the repertoire gets more restrictive rather than just kind of getting better as time goes by. OSFED, this is just the things that don't quite fit into the other categories that I've talked about. Quite common versions of this is atypical anorexia nervosa, or a normal weight anorexia nervosa. This could be somebody that's come from a 26 BMI, for example, down to a 21 BMI in quite a short duration. And they might have all of the same cognitive and psychological features of anorexia nervosa, but they don't meet a BMI lower than 18.5. Really important to be on the lookout for those kind of cases as well. Purging disorder, so that's a bulimia but without the binging, so they're usually in a normal weight, and there's vomiting behaviour typically, or it might be laxatives happening, and night eating syndrome.
There was a question here, Marion, saying, actually two questions about the possibility of orthorexia nervosa.
Yeah, sure.
Yeah, and whether food choices and weight are controlled by the perceptions of the right foods that you eat. So is that regarded as a disorder?
Yeah, look, orthorexia isn't a diagnosis. It is a bit of a coined word, which makes sense. And we certainly see it in the clinic as well. More often than not, what starts out as a bit of an orthorexia, clean food eating, paleo, then I'm vegan, it kind of spirals, and then we end up in an anorexia nervosa.
Okay.
So it's kind of a pathway into.
Okay. Yes, that makes sense.
But very much a real thing, and very much something that presents really similarly. Yeah. Okay. Because naturally, again, those rules about food and what you can and can't eat, they get more and more and more restrictive, and then we get weight loss quite often, and then we get secondary effects of starvation kicking in. Yeah. Okay. Yeah. So really good to be aware of those sorts of things when people are being very strict with diets and lifestyle choices. Yeah.
Yes, which we see quite a lot, don't we?
Sure.
I think, but and sometimes within a realm of normalcy, I guess. But there's a spectrum.
Yeah, there is a spectrum, and I think that's exactly the point to be looking for. It's thinking, what impact is this behaviour having on this person's ability to do day-to-day life well?
Yes.
If it's having no impact, great. But if they're not going out for dinner with those friends anymore because that restaurant doesn't suit my dietary requirements, so now I'm missing out on social things, and then I can't concentrate in this lecture because I'm thinking and planning what's happening for my next meal and what am I doing. These are starting to become life interfering.
Absolutely. Yeah. And the other question we have here is a person who's written in says, I have a patient who has changed from anorexia to binge eating disorder, and is this a common transition? Do you see this a lot?
Really good point. Yeah, that's a great point to raise, actually. Sometimes, it depends on the case. We have some clients that tend to fall very much in that restrictive end, and that's where they present and that's where they stay. And they're very different to the clients that are right at the other end, that are in that binging, purging, trying to control but loss of control phase, and they tend to stay as well. So there's these two distinct groups, and then you've got your overlaps in the middle. Sometimes when somebody has had a low weight anorexia nervosa, it's almost like they need to relearn how to eat normally again. So you have this pendulum effect where they've come from incredibly restrictive eating, and then the pendulum's gone a bit too far this way, and now they're overeating, and then maybe they feel binging because they are feeling out of control, and then they need to do something about it. So then it develops into a bit of a bulimia. But I often would be quite cautious in then saying, okay, now you have bulimia nervosa, because they might just be on a recovery pathway, and they're just finding where that balance is settling again in terms of how do I eat well. It's really, really common to hear people that have had anorexia nervosa, particularly when it's been a number of years in the illness. They just don't know what's normal anymore. They don't know what a normal portion size is. They don't know, they've lost all of those internal cues of hunger and satiety as well. So they need to relearn doing that. And as part of relearning, it's really common for that to just swing a little bit till it finds its balance.
And that support during the time that you can offer.
Absolutely. Yeah, absolutely.
We have a question here that says, I have several patients with personality disorders and have been declined an eating disorder diagnosis that they're not strictly anorexia or binging. For example, a patient who has had a BMI of 40, limited oral intake, using laxatives. Is there much overlap, I guess, that's what they're
between personality disorders and eating disorders? Yeah, absolutely. And particularly in those more binging presentations where you've got those impulse dysregulation personality traits, if you will. There's a lot of overlap with what we see in borderline personality disorder. So that dysregulation is regarding food and eating, and we also see dysregulation in day-to-day life and in impulsive behaviors, and maybe it's stealing, or maybe it's those emotional kind of ups and downs, and how do I navigate that? Maybe it's self-harm behavior. Those they kind of almost cluster together as impulse dysregulation symptoms. So it's very common. I forget the exact stats on it, but we see a lot of borderline overlap with bulimia nervosa presentations. And actually, while we're on comorbidities, in the anorexia end of the spectrum, we're much more likely to see those kind of social anxieties and performance anxiety, generalized anxiety. It's more that end of the spectrum.
High achieving, that's still a problem.
Quite often, quite a lot of perfectionism. Often, so they're doing incredibly well at school, and they're doing incredibly well at being anorexic as well.
Let's carry on through, Marion. So I had a few more questions, but we'll get to them, I think, as you go through these.
So how to do assessment, what to look for in the 15-minute consult. So we're screening for high-risk groups. So the adolescents, as we've mentioned, tend to be younger for anorexia nervosa and a bit older for bulimia nervosa. That age of onset of 18 feels for me a little bit high, although that's the stats. But I mean, again, kind of those bulimia presentations are more, you're kind of 16-ish, maybe 17, 18, whereas anorexia, we can see quite a bit younger. Most often females, but don't forget males. It's important that that's not off people's radars. The stats we have at the moment is about 9-1, but that's shifting, and it's actually dropping down. The better things are recognised. During key life transitions and hormonal transitions, these are risk periods as well. So schooling into adult life during that adolescence, which is why we see that there, but also pregnancy, both for initial presentations and subsequent presentations, and then also menopause. So we're just beginning to understand the last kind of 5 to 10 years that there is this group of women with first presentation eating disorders around that menopause age as well. We have elevated body dissatisfaction in women with PCOS, so that's an important thing to have on your radar for those patients, also those with diabetes. And here's another term like orthorexia, we have diabulimia, where the purging method is the insulin. And then we have athletes and dancers, so people that are in these high body focus, high pressure kind of settings. Family history of eating disorder, these are biologically informed illnesses, so always good to have on your radar when you know that there's a family history there. And those that are seeking help with weight loss, those kind of dieters, people with a real diet mentality, if you will. They may not, but it's a good thing to check out.
That's that trying to be good.
Yes, exactly. Yeah.
Thinking.
Absolutely. So behavioural symptoms to be looking at, and I've underlined some of the more common ones. So fussy eating or banned foods. So being on the lookout for if they're talking about, oh yes, that's an okay food and I'm not allowed those foods. So good and bad foods, or permissible, not permissible foods. Cooking for others but not eating, that's a real, quite an anorexia behaviour there. Excessive exercise, so exercising even if it's pouring down with rain and most other people would have stayed in. They're determined and out they go and do their exercise, or they've got an injury but they're exercising and going to the gym anyway. I mentioned restricted and rigid diets. Excessive use of the bathroom, which could indicate purging. Constant focus on food. The lower that you get in your in BMI, so the more malnourished your brain is, the more malnourished your body is, and your brain is, the more the cognitions are trying to seek and find food. So that proportion goes up to, oftentimes it's 80-90% of their day where their thinking is based around food and eating and sourcing. So when there's a lot of talk about that, that's a really good indicator as well. Denial of the problem. So again, I know I mentioned that already. Hopefully people take that one home with them. And this kind of developing allergies. So lots of I've got celiacs, or I've got a dairy intolerance, and maybe they do, but maybe they don't, and this is just part of the slippery slope of eliminating food groups. Psychological symptoms, so anxiety, we've talked a little bit about this, depression, social phobia, distorted or negative body image, feeling lack of control, suicidality, poor concentration, perfectionism, low self-esteem, guilt, obsessiveness, cognitive changes. We see subtle cognitive changes, things like becoming even more rigid in cognitions, inability to flex, inability to be responsive to novel situations or changes in circumstance. And you can see there's a lot of overlap here as well with depressive symptomatology.
Yeah, that's right.
Yeah. And then our physical symptoms. So sensitivity to the cold in people that are underweight, brittle nails, dorsal fungal calluses. We call these Russell's signs, so it's from self-induced vomiting. Fractures, muscle cramps, dental issues. We talked a little bit about amenorrhea already, things like anemia, gastro symptoms, dry hair or skin, and that lango hair quite often. That can be a bit of an indicator. Feeling cold and faint, injuries from overexercise, self-harm, early satiety, halitosis, these types of things, important to be on the lookout for. And I'm going to talk to some resources to equip you around this. So the physical exam, so height and weight, really important to be doing this. Pulse and blood pressure, we want to have standing and sitting as well. Oral temperature, periphery exams. I'll perhaps let people read through that one there. But essentially trying to look at how is the state of the body, how is the body managing, how is the body coping.
Yeah.
These things oftentimes are much easier identified in a more severe state of malnutrition.
Yeah.
Okay. Lab investigations, this comes back to the question that somebody asked before. Look, what I need to do here is really acknowledge to not step outside of my scope. So I'm a clinical psychologist, I'm not a medical doctor, but certainly these are some things from my experience working within this field that it's important to check out and to look at.
Okay, there was one question on those lab investigations. There was one about general check, and obviously you had liver enzymes as part of that there, which is something that's regarded as important to look at. How common is it to see abnormalities in their OBS and their bloods? You mentioned before that often the OBS can be completely normal and not to rely on that. Same with the bloods. How common is it that you will see someone who is actually quite unwell but has a normal blood test?
Yeah, look, I think it's reasonably common, and the longer that they've been in a malnourished state, the more the body seems to adjust to that, and therefore looks like it's doing quite well.
Yes. Yeah.
I've seen clients at a very low BMI, 14 to 13.5, who have had chronic anorexia nervosa, and they've actually been medically stable at that BMI, which is quite astounding. So it's really important to see it in the bigger picture, right? And make sure you're taking all of the information into account. And saying that, and particularly in a young person who can become medically unstable really quickly, it's important to know that somebody that might have gone from a 23 to a 19.5 BMI, they might become medically compromised at a 19 BMI.
Yeah, that's right. So it's different. Yeah,
absolutely.
There's been a specific question around ESR and why in particular that was a good test to be done. Is there something in the guidelines that explains why ESR is a particularly relevant test?
I don't know.
Yeah. I think ESR has become one of those things, hasn't it, that goes in and out of flavour. So maybe that's something we should look out separately in the guidelines.
I think so, yeah. And look, I'll refer you to that. And again, I just really want to acknowledge my limitations in terms of the medical side of things. But certainly there's some really great things I can point you towards.
That's right. We'll link these guidelines and any other references that Marion has to the webinar, so we can go and have a look at and see if there's anything else in there that we need to know about.
Fantastic. Okay, speaking of which, this is one of the ones that I would really recommend. This is a lovely summary type paper. It's about 5 pages long, which is nice, so it's a quick read, and it's got a really lovely full summary of eating disorders for general practice. So I highly recommend that one there. This is another one. If you Google Maudsley GP Guide, you should come up with this PDF document. Again, it's about 6 or 7 pages long. Very comprehensive and talks about elements, not only medical monitoring, but engagement and those sorts of things. Really great resource to have and one that's quickly read. If you've got a little more time, the clinical practice guidelines are there as well. Nice guidelines, which are getting a little bit old now, but it's still relevant. Quite a big read. We have the Royal Australian New Zealand College of Psychiatrists clinical guidelines that actually I would highly recommend. The lovely thing about these is that they have fantastic summary tables at the back, quite a few of them. So it's a really great to print this off, have it in your drawer somewhere, and use it as a reference.
Okay. And we'll link all of that to the bottom of the webinar there, as well as this tool.
Great. So this is a lovely tool for primary care, the SCOF questionnaire, 5 questions, that gives you an indicator across these different elements. So do you make yourself sick because you feel uncomfortably full? Do you worry you've lost control over how much you might eat? Have you recently lost more than, I'd probably say, 5 kgs over the past 3 months? Do you believe that you're fat when others tell you you're too thin? Yeah, that's a really nice one for picking up that dissonance as well, and whether they've got some insight there. And would you say that food dominates your life? Again, that comes back to the cognitions and the strength and the time that the cognitions are taking up in their life. So again, if you Google SCOF questionnaire, that should come up pretty much straight away, and we'll have them linked as well. So other options, and these are just from my experience, some good questions to have in your toolkit. So does your weight affect the way that you feel about yourself? Are you satisfied with your eating patterns? That can kind of go places, that one there. Can you tell me what you ate throughout the day yesterday? So this is a good one if people are finding it hard to talk to this, but you really want to get a little bit more detail. Yesterday's a good day because they can remember it, and also it's tangible. So if you say, what's your eating like, it's kind of a bit too open-ended, whereas getting that food intake throughout the day can be quite useful. What do you think about your current weight and shape? So again, a good question. You're looking at level of insight as well, depending on what their BMI is. And have you cut out any food groups recently? I mentioned this earlier, but I'll say it again. Looking for non-verbal information when you're asking these kinds of questions can be really, really useful. Not only when you are trying to explore this a little bit, but also when you're doing weighing. I always do the weight myself in the clinic room because you get a lot of non-verbal information by whether they're getting on the scales, what they're like when they're getting on the scales, how they respond to that number.
What they're wearing when they hop on the scales.
Yes, well, that's a good one. What's in their pockets as well.
Yeah,
absolutely. So is 15 minutes enough in the context of all of this? I think we can all agree that it's not. And you mentioned this before, consider inviting them back to do a bit more of an investigation and assess fully. So just to be aware of, this is probably repetition, but you've got likely ambivalence about recovery if anorexia is presenting. If they're in a really entrenched state of the illness or reasonably malnourished, there's that potential that they're actually thinking really positively about this illness. You know, I'm doing great at this. Look how much weight I've lost. So that lack of insight is really important, denial of the seriousness of it. Likely that anorexia might present for other issues. Maybe it's depression, maybe it's fatigue, maybe they can't concentrate at school or at uni, maybe they're highly anxious. All those injuries as well. And if bulimia and binge eating disorder are presenting, really there's quite a bit of shame, quite a bit of stigma, and it's quite likely that there's non-disclosure happening there. So just kind of being aware of those things again as well. Sometimes a concerned parent will present in the absence of a young person, and I'd really encourage GPs to listen well to what that parent is indicating as well. Above all, a warm, empathetic and non-judgmental clinical stance is absolutely critical to facilitate rapport. And if you don't have good rapport, you're not going to get an accurate assessment. So it's really, really important. And that's the lovely thing, I think, about being in that primary care role, whether it's GP or practice nurse, where you have this relationship already. And so you can build on that. Okay, so I want to talk briefly about treatment and referral. GP's role in eating disorder treatment, so it's in that space of assessment and potentially an initial diagnosis, although it may be more appropriate to refer it out for a comprehensive assessment and diagnosis. Now, NICE guidelines tells us that if an eating disorder is suspected, refer immediately to a community-based age-appropriate eating disorder service for further assessment or treatment. Isn't that lovely?
It would be wonderful, wouldn't it?
In the future, I hope that this will be a reality for every case. I mean, there's a whole thing we could go into there, but I think the take-home message really is that if you can refer these people,
you should be doing so.
Absolutely. Urgent referral to emergency department if indicated by medical instability, and I'll flag this in the next slide. GP, it's really important that rapport is developed and maintained, because particularly if you're engaging with an outpatient service, the GP is likely to stay in a role of medical monitoring, so that's important. Medical monitoring there. Treatment of any complications like anemia, nutritional and weight assessment. Again, this depends, I guess, who else is in the treatment team. So quite often, like in my private practice, we liaise very closely as best we can with GPs, but we often hold the weight because we're seeing them weekly, so we're getting that consistent picture. So it's about having that dialogue with your treatment team as well. Education for the patient and family, this is really important and unfortunately oftentimes missed. And I mentioned briefly EDANS before in the case study. This is a volunteer support organisation in New Zealand that's run by carers, mostly mums who've had a daughter that's gone through an eating disorder, and they have a telephone helpline. They're fantastic. I'll show you a slide about them later, but this is a valuable resource for parents.
Just before you go on to the instability side, there was a question here about the early intervention and the referrals like we've talked about. So if we suspect or we see that there is some leaning towards an eating disorder, or we think there are some behaviours associated with an eating disorder, yet they don't quite fulfil the strict criteria, is that an appropriate time to refer if possible, whether it is publicly or privately, and the person is willing to do this? But is that okay from the point of view of a clinician?
I personally, I would rather see a young person and assess them and go, do you know what, this doesn't look like a full-blown eating disorder. Let's do a couple of sessions of working about maybe you see the dietitian for some dietetic education. Let's have a little chat about, how things are going at school. Maybe see them for a couple of sessions and off they go. I would much rather that.
It's that early intervention, isn't it? That idea that you're picking it up before it becomes a real medical problem.
Absolutely. Because the longer it progresses and the more it ingrains, the harder it is to get out of it.
That's right.
Absolutely.
Okay. Thank you.
Pleasure. So this is one of those tables that I mentioned that is in the back of those Australian New Zealand psychiatry guidelines. So nice and clear, you can flick through, you can check it out, and it tells you.
That's really helpful if we're following up. And people have asked about the different lab tests and the results, so that's a really helpful resource.
It's a great resource for that. So there's pages and pages of these tables. It's really fantastic. Here's another example. So this is the psychiatric admission indicated based on medical parameters and the medical admission indicated. So again, you can look through this and familiarise yourself with those recommendations.
So it's very handy, like you said, to have something like this available in your clinic within reach, so you're not sort of searching for something to tell you what to do when you come across a patient that's coming in like this.
Absolutely, a really good resource tool. Just popped it up there again for you. So that's this one here on the left that I'm talking about. Referral pathways in New Zealand, and my apologies if I get this incorrect for anybody outside of Auckland. I'm very Auckland-centric with my knowledge on this. So as a GP, you would refer to the CMHC, the Community Mental Health Centre, or the Child and Adolescent Mental Health Service for a case like the ones that we're discussing. They would then assess, and they'd either hold or they would refer on to a specialist eating disorder service. They can also liaise with the specialist eating disorder service. So in Auckland, that's Tupu Ora, our regional eating disorder service, or what used to be called REDS. So they offer outpatient treatment. They have a day program for adults. They have a residential program which has, I think, 8 beds, and there's also some beds in Starship that are designated for eating disorders as well. The Tupu Ora specialist GPs are available for consult. I believe you can just ring them up if you wanted to run something by them. In Hamilton, there's an outpatient service there, and in Wellington, they've got outpatient and residential, and Christchurch outpatient and inpatient. Same pathways. GP refers to CMHC or CAMS, and then they assess and hold, or they assess and refer on. And just to note that there's also private outpatient specialist eating disorder practices as well, such as the one that I practiced out of. Specialist psychological interventions. This is one slide, very brief. So for child and adolescent outpatient anorexia nervosa, our treatment of choice is FBT, or family-based treatment. It has the strongest research evidence. There are families with which this doesn't prove a good fit for. The stats are around about 35%. So in those cases, it's then appropriate to consider something else that might have a stronger adolescent focus, where you have an adolescent that really wants to have a voice in treatment. Outpatient adult anorexia, we have a couple of different treatments. You've got some nice acronyms here. Really, there's no great evidence prioritising one of these over the other at the moment, but this is very much an ongoing area of clinical research. Yeah. Binge eating disorder and bulimia nervosa, we have much better evidence for this. This is much more treatable, I guess. CBTE, which is CBT specific for bulimia nervosa presentations, has really great efficacy. The numbers are about 75%. So it's a great treatment package. Yeah, it's a really good treatment package. This is not stock standard CBT, it's CBT specific too. So it requires a trained clinician. And then we have day programs where we have multidisciplinary teams, there's group therapy, there's supported meals, and then there's some individual psychology or counselling and dietetic sessions, so such as what's run here in Auckland at Thrive, and then residential where it's also MDT, but with 24/7 nursing staff as well. Okay, so to finish, talking about some resources. So online, I've talked about the practice guidelines already, and these are really some other things that might supplement that. The Academy of Eating Disorders, which is our international body, has a really lovely what's called the Purple Booklet. So again, if you Googled AED Purple Booklet, it will probably come straight up for you. A really comprehensive medical care standards guide. That's a good one to know about. NEDC in Australia also have a professional resource for GPs, and ANZ also have great information on their website that's worth having a look around as well. This is EDANS, who I've mentioned 3 times now. I'm really a big fan of the EDANS group. So they have a really good information-based website that I'm showing you a screenshot of here. So credible information, helpful information. They also run a helpline that is free for carers or professionals, in fact, to call and have a chat there. So they support a lot of parents throughout New Zealand using that helpline. This is a lovely infographic that I think is fantastic. I was thrilled when I stumbled across it. If you Google the BMJ Eating Disorders infographic, this should come up on Google Images for you straight out the gate. It's a really lovely flow chart of navigating that primary care assessment for an eating disorder.
Again, something useful to just have in your clinic, isn't it? Available.
Absolutely. Absolutely. Yeah. Really, really good. So talking briefly, just stepping back from eating disorders and thinking about mental health in general, just wanting to flag a professional development opportunity. So I'm based here at the University of Auckland in the Department of General Practice and Primary Healthcare, and I run 2 courses here. The first one, Semester 1 course, which is Adult Mental Health and CBT Skills for Primary Care. I'm biased, obviously, but this is a nice little course, and the 2-day block course is really practical. So all of the learning is done online and through online lectures or discussions or readings, and then the class comes together for a 2-day block course where we really focus on how to do CBT well in that kind of 15, maybe 30-minute consult and a real short intervention. So that's a really great one for people wanting to upskill across the mental health spectrum. And then Semester 2, 754, is a sister paper for that, Child and Adolescent Mental Health for Primary Care, which is really based on significant upskilling. Lots of fantastic guest lecturers in this one as well. So psychiatrists from Starship, for example, and the Curry Centre, which is a really great CAMS service here in Auckland. So you can take these papers standalone. It's what's called a certificate of proficiency, so just as a one-off if you want to upskill, or you can do it as part of a postgraduate certificate, diploma, or master's. Now, I believe that if you work for Counties Manukau, you can get funding for these courses. Just throw it in there.
Well, thank you, Marion.
Pleasure. I'm just going to leave this for people
while we talk. Yes, because we've got a few questions coming through. So thank you for all your questions, and thank you, Marion. That was an amazing overview and some really good practical tips, which I think have been really helpful. And people have written in saying, look, this is really great because I work a lot with adolescents or have seen a number of patients with this, and these are helping me give some tools and resources.
Fantastic.
So thank you.
Yeah, great.
There's a couple of questions. One we'll start with. it's a slightly different one. Do patients prefer to see clinicians who themselves have certain body types?
Yeah, look, that's interesting.
Yeah.
It's I think it's something that is on everybody's radar, but it's not something we talk a lot about.
Yeah.
I can see that somebody, if you're, for example, a very underweight patient and you're seeing a therapist that's in a bigger body, that would be maybe quite distracting for the client in the room. Maybe it's not. Maybe they feel quite comfortable in there. It's just something to really be aware of and to have on our radar. It's not uncommon to be sitting in a therapy session, for example, and notice that your client's body checking you. So that absolutely can happen.
Yeah.
Sometimes it's helpful to name that if you have the relationship with them, to be able to do that. And other times it's just information.
Okay.
But I think it's a good thing just to be mindful of.
And it's possibly, as you say, one of those non-verbal signs that someone has really got disordered thinking or psychological sort of reliance on thinking about body type or eating. If they're body checking you, as you say.
Absolutely.
I like that phrase.
Yeah.
Another question has come along saying, when patients have been abusing laxatives for a prolonged period, is there an ongoing dependency for laxatives in terms of the bowel functioning? And this particular person has a patient currently tapering down from 80 a day.
Wow.
And they're one a week, they're dropping one a week at the moment.
From 80 a day,
obviously, I mean, that's a huge change for their bowel to cope with.
Absolutely.
Do you see this very often, and how do you tend to manage this?
Yeah, I would say I would pack them off to their GP, to be honest.
Yeah.
So, do you know, it's a really good point. I don't know what would be appropriate in terms of kind of frequency of trying to titrate that down.
Yeah.
I think what I'd probably suggest here is A, check out what the guidelines that I've referred you to might say on that.
Yes.
And B, for example, if you are in the Auckland area, chatting to the GPs at your order can help in terms of treatment planning, that kind of thing.
Yes, because they've probably specifically dealt with a number of people with this, they'll have experience as to what has worked and what hasn't worked in the past.
I think that'll be the most helpful.
Fantastic. We talked about early intervention and referring, which was great. How often do you see a history of sexual abuse and other early childhood abuse and adverse child experiences associated with these clients that have eating disorders?
Yeah, it's what we call, I believe, the research calls it a medium potency risk factor for bulimia nervosa. It's less likely for anorexia nervosa, but certainly a history of trauma does often come up in bulimia nervosa presentations.
Is there a reason why that's different, the bulimia versus the anorexia?
Yeah, I think it comes back to that natural tendency. If we think overarching, one is about over control, and one is attempting to control but dysregulating.
Yes. Okay.
So we're much more likely to see those negative life experiences in people that are more at this kind of at the that spectrum.
Yeah.
Now I was going to say something else on that as well. Adverse childhood experiences. If we think about dieting as an adolescent, this is interesting in the risk factor literature, is that dieting and around that, I believe it is early adolescence, 12 to 14 range, is a high potency risk factor for bulimia nervosa, but a low potency for anorexia nervosa.
Again, see, I wouldn't have picked that, but that's interesting. And again, why? Why do we think that is the case?
So the dieting, it seems they're trying to develop that kind of follow some rules, but then potentially can't stick to those rules, and then we flick the other way.
So it's sort of try and fail.
Exactly. So then we get into this yo-yo type relationship,
and that negative thinking. Gosh, it's complicated. Does parotid enlargement take a long time to settle if a bulimic patient recovers? Does it ever settle? Because we often do see patients with that.
I would have to ask you what that is.
So that's where you're going to have your parotid glands, where you see them swelling, and that's with bulimia patients who often. That's right.
The chipmunk checks.
That's right. And I think I'm from experience, you see this often persisting into recovered bulimics, and have you noticed or seen the difference?
I haven't from experience. I probably again, this is probably me stepping a little outside of my scope, so I'd say probably that's a great question to ask the GPs.
here we go. With the example of the binge eating disorder in the 38-year-old mother, I suspect I could classify the majority of my female patients along these lines. How prevalent is it? And is it helpful to give this disorder a name for those people? Or do we try and help them without sort of labeling them with something?
Look, it's a great question, because for some people that label can be a huge relief. Where they're like, oh, that's what it is. And then you give them some reading attached to that label. They're like, oh my goodness, that's exactly what's happening for me. Really validates the experience for them, and it makes them feel like they're not alone. So there's a lot of potential positives to giving that diagnosis, assuming obviously that you've done a good assessment and that they do meet those criteria. For other people, the flip side could be true. So I think it's one that's about kind of getting to know your patient well, doing that assessment really well, seeing what's the level of distress and impact that this is having on them, and that would be what would guide me in terms of where to take that.
And possibly putting importance on it, so saying, look, let's not try and solve all of this in our 15 minutes, bring them back like you suggested, and have a further discussion around it, and then as you're processing how that patient is responding to what you're saying, whether it's a diagnosis or a label, whether it's a discussion, might leave that.
Absolutely. And thinking about questions such as, what kind of an impact does this have on your day-to-day life? Because maybe it's something that's happening, but they're like, well, I'm not really bothered by it.
I'm just getting on with it.
Totally. And if there's no level of distress and there's no marked psychosocial impairment, then we're probably less inclined to give it a diagnosis.
But it might be a discussion around
the
healthiness of the behaviour.
And how we're taking care of ourselves well, and are there some little goals that you might want to put in place when it comes to taking care of yourself well.
Okay. I like that. I think that thinking. In your experience, can medication to treat the underlying depression or anxiety help treat the eating disorder?
Really nice question. So there is no evidence to say, this is, I believe, that antidepressants treat the eating disorder well. But like this question is asking, there is good evidence to say that medication treating the depression and therefore lifting the mood makes them more able to engage in treatment for the eating disorder, and therefore can have a knock-on effect. So to put it into more real patient terms, I've worked with many patients that have been on an antidepressant and seen a change in them and how they're presenting, which then just makes them more able to do the work that they need to do around shifting eating patterns, because they've had that lift in mood, and so they can turn up better. So by all means, sometimes it can be an incredibly helpful aspect of the treatment. But where we don't have depression, then my understanding of the literature is that we don't really have a medication for eating disorders. So that wouldn't be indicated in the absence of a comorbidity.
Okay. And actually someone specifically asked in here, do SSRIs have a role in management? So that flowed that up there. At what point can you consider adults with eating disorders not to be able to decline treatment? So when do they become not competent enough?
And we're talking about Mental Health Act.
That's right.
Look, I think that's something that I know is activated as an absolute last option, and something that's typically done by a team. So this is people in maybe they're in the residential care in Thrive or known to those services, or maybe they are needed to be admitted to hospital against their will. But there's a lot of wraparound clinicians there making that call. So some of the medical indicators, obviously, we can get from those medical guidelines that I have flagged up. So if we have got clear parameters there indicating we need to admit, then that's probably going to be a large piece of the puzzle, I'd imagine.
So if someone presents to you for the very first time and they're clearly very unwell and they need inpatient treatment, then you've been able to use those as your backup. But otherwise, a lot of people will have those wraparound services already in place. Okay. What treatment exists currently for ARFID in New Zealand?
Look, we're really at the early stages when it comes to treating ARFID. Typically, we are looking at kind of a CBT, almost an exposure hierarchy type approach, psychologically speaking. So starting with the repertoire that they're accepting, and then just gradually working on small bites or a little bit something new, and trying this one new thing, and they're just having a very small amount. So it's very small, and it's it's really following that similar exposure hierarchy that we have for things like specific phobia. There is some early evidence that family-based treatment, which I mentioned before, which we use for adolescent anorexia nervosa, might be helpful for ARFID, but it's very early evidence. There's also some early evidence that this more CBT exposure kind of approach might be useful, but we're right at the beginning of figuring that out.
So watch this space. It's a really developing area.
Absolutely.
And then if you wanted some advice, if you felt that you had a patient that fulfilled that, is it through the same resources that we're going to ring and ask, so that they'll be aware that it is developing and where to direct you?
Yeah, absolutely. I mean, I know in my experience with we see a number of kids with this kind of thing come through, and sometimes it's just really helpful for the parents to have a really good assessment, both a psychological assessment and also a really good nutrition assessment. So we know, are there things that this kid is missing in terms of macronutrients? Sometimes that in itself is really helpful just for lessening family anxiety, and thinking about, is this enough? Are they actually just getting what they need? Do we need to kind of be pushing here really, really hard? Or can we take a different approach?
I have a case here. Okay, I'm talking through. So do you have any advice regarding ongoing management for a 15-year-old who was diagnosed about a year ago with anorexia nervosa, went through Maudsley family therapy with SEDS, and was discharged as her weight rose into the healthy range. However, she has ongoing very disordered body image, extreme restriction, increasing anxiety, including self-harm. This person is seeing her for medical monitoring, and she has some regular counselling input. Lies to a counsellor, lies to you, as you said, anorexia nervosa is an excellent liar. I'm worried this is going to become more severe, and she's effectively no better than when she was diagnosed, despite having gone through this big process. Many thank you for any advice that you might have.
Look, it's a really hard one, and unfortunately it's not a rare concern where somebody has been through FBT with that focus on weight recovery, but sometimes maybe they're not ready to do the psychological work that's left over, or there's no resource to do that work, but that's a really big piece of the puzzle. So it's really important that psychological work of the underlying kind of predisposing and maintaining factors is addressed as well. And actually, if I flick to, if people are still looking at the screen, got a little wee image on this next page, there's so much more to recovery than weight.
That's right.
And I think, the reality of it is that our services are oversubscribed, and people are absolutely, and clinicians are absolutely doing the best that they can, but sometimes for whatever reason people do end up finishing treatment when there is a big piece of work still to do psychologically. And oftentimes we see cases in private as well that have done really good initial work, but there's still something that needs to be done, and that's that more underlying kind of psychological work.
And that's probably the longer process, the long term.
It can be.
Input.
Absolutely. So I don't know that I can really. I don't know that that's very helpful.
No magic answer, I think.
I think it sounds like for a case like this, they still need to be engaged with some kind of specialist psychological work.
And even possibly flagging to that patient, look, you've done so amazing with this one aspect of your recovery, but this is just as important, and it will take longer and more work.
And if they've done all of that work and they're actually holding that weight recovery, that's really impressive. It's really impressive.
Yes, that's right. What is a brief GP intervention that is useful prior to the patient accessing secondary care? So if they're waiting on their referral appointment, and what is the role of the family in this?
I think the family can be huge. They can be a game changer if you can involve the family. If you have a family system where that's going to be helpful, which is typically the case, they can be so great just to loop in to that process. Early on, in terms of the GP intervention, I mean, a lot of psychoeducation can probably be quite helpful. That's usually where I would start with most cases. It depends what kind of patient we're talking about. Somebody that's got more of a Bulimia Nervosa presentation is going to be much more responsive to psychoeducation. Somebody with a very low weight anorexia nervosa is probably not going to want to know about it. So it's really about kind of testing the waters, but certainly the medical monitoring, certainly trying to do a little bit of psycho ed if you can, and if it's not if the patient's not as interested in the psycho ed, then certainly providing that psycho ed to the family anyway, and just encouraging them to be active and to be present, and to give EDANS a call maybe.
We're almost out of time, so we're going to do the last couple of ones very quickly. Where can you send those who are not responding to FBT or any form of CBT? Where's the next step?
That's a hard question.
Is it a step sideways? Is it trying someone new in the same space?
Yeah, look, that actually raises a really good point, which is that when it comes to psychological interventions, we know from years and years and years of research that a huge part of what predicts response to psychological intervention across the spectrum of mental health is the therapeutic relationship. So regardless of whether you're doing CBT, IPT, DBT, AFT, whatever acronym that we're doing, if that therapeutic relationship isn't strong, then it doesn't really matter if you pick the fanciest therapy and had the fanciest training. It's about how safe that client feels in the room with their clinician. So it may just be that somebody might want to try out a different therapist and see if they're a better fit for them.
Which is a reasonable form. And lastly, in terms of the resources that we can give to our patients, so you've talked about the EDANS and the other resources that we have on there, and would they be useful actually to give to patients or to refer patients to those websites?
I would. So EDANS is more focused on supporting the supporters. So they're more for the families, the carers, the loved ones, the parents, the partners, that sort of thing. In terms of somewhere to send the patient to, that can be a tricky one online because there are lots of what we call pro-ANA websites, pro-anorexia websites. Less so these days because places like Instagram have actually done Facebook actually have done a reasonably good job at trying to bring that down. But that's, I think, the risk with sending them online for anything is that it can sidetrack into something that's incredibly unhelpful but maybe masked as helpful, but actually is just encouraging the eating disorder behaviour. I tend to stick with good old printed handouts with credible information on them, and just being really strategic with what I pick and what I give to them that's relevant for that individual formulation and not overwhelming them. Is there somewhere that or a link that we could put on for our viewers of where we can access some printed handouts that we could use in our clinic? I think we could find something.
That would be great. So we'll look into that for you. Thank you, Marion. We're out of time, so thank you everyone for your questions, and thank you for your really helpful discussion. It's been so practical, and I think incredibly useful for people who are either seeing patients like this now or may in the future. And obviously there's all the upskilling that we can do and the resources that we'll have available. So
absolutely. No, it's an absolute pleasure. And I've said here, please feel free to contact me. So I've got a couple of email addresses there. One is my academic email there. So I practice at the moment at Shelley Beach Practice, which is in Ponsonby, and also very excited about nurture psychology, which hopefully is opening in the next couple of months, which is going to really focus on that early intervention space that I'm really feeling really passionate about. So,
all right. Well, look, thank you, Marion, and thank you everyone for coming along. We'll see you next time. Thank you.